listening to you complain about this the entire time.
Oh, I'll be fine.
Ibuprofen
will take the edge off.
Right.
Oh,
We haven't even gotten started yet, and you've already hurt yourself. So, all right, welcome back to Conflict of Leadership Coffee Table Edition. Are you done?
I got to keep the ice pack on there somehow, and it's not working very well.
Gosh.
All right, welcome back.
Yeah, well, welcome back. So, Jeremiah, why don't you tell the world what you did?
I have a concussion.
You have a concussion.
Oh, yeah, that hurt. Standing up in the back of the squad to reach over, hit your head on the cabinet, put you right back down on your derriere.
It helps when you don't hit the. I still don't know, how did you hit the cabinet?
I was sitting down on the bench seat.
Okay.
And I didn't stand up all the way. I stood up like halfway and reached over. And I went too far. Bam.
That took some skill, because that's like 5 feet that you had to like lean over.
You realize how tall I am, right?
You're not that tall. You ain't no Michael Jordan.
If I was, I'd be rich.
No, you'd be a discount is what you'd be.
I'm already a discount. Are you kidding? I'm like Dollar General discount.
Oh, boy. So conflict of leadership, where we talk about how we hurt ourselves incessantly. I mean, yeah, it does hurt, but
oh Lord, we need some curtains for that window.
We need something. So conflict of leadership, where we talk about everything in the fire service and how it affects us, how things are changing, and just kind of our outlook on things. So, besides your headache, how are you doing?
Oh, I'm doing great. Today's been a good day.
It is beautiful.
Doing God's work today.
Are we?
We just did God's work.
Oh, okay, fair enough. No, it is beautiful out today.
It is.
When we
it really is.
Doing our pump stuff today, it's going to be absolutely.
Yes.
Just don't get wet. It's going to be very cold if you get wet.
Yeah, I don't want to get wet, but if I get wet, you get wet.
Yeah. So, oh boy, yeah, fall time's here. Next week we got Captain Trey doing our winter operations chimney fire. So
that's almost in full swing now. It's starting to get cooler and cooler, people. I'm
kind of surprised with some of these cooler nights we haven't had one. Yeah, I've smelled some people's wood burners and whatnot, but we haven't had anything yet.
Yet is the key word.
Yeah, so here's your PSA, ladies and gentlemen. Clean your chimney flues. Have a chimney flue come out.
Yes.
If you have a wood burning stove, fireplace, anything you use throughout the winter, get it cleaned. Get it inspected. Get it checked. Please. It is the best way to prevent a chimney fire and then a structure fire.
Yes. I don't want to come visit you at 2 o'clock in the morning.
Not because we care about waking up, but because that's just not a good time to meet somebody.
No. No, it is
not. Stop vibrating over there.
Not me. That's all you there, sir. My phone's in my
phone
pocket.
Is elsewhere. Oh no,
it's on your case.
So yeah, we're appropriately loopy today, which I guess is a good thing. You're drinking.
I'm concussed.
You're drinking more caffeine.
It'll take away the pain.
Oh boy. So, well, today's topic. So, kind of going off of last week. So, our I'm calling it our Great Reset. I hate that term because of what that term has meant. But that's kind of what it is. So we're going to talk about something that's very near and dear to your heart because it's the stage you're in, private ambulance world. So,
oh goody.
So for me personally, I've been displaced from private ambulance world for about 6 years now. I spent the first half of my career working different private ambulance companies. So I've got a little bit of a general idea of what it's like, but been there pretty much for the duration. So, yeah.
I've seen its ups and downs in this area, especially the region of this side of Ohio. Good and bad.
Yeah.
And it's just still the same. Nothing's going to change. Like, I'm just going to say their name because everybody knows who they are. AMR.
Yep.
They were gone from Ohio.
Really?
Yes. They are shut down.
I did not know that.
As of last fall.
That That was a huge company. They were literally everywhere around here.
Oh, and they were, and that's where I got my start at AMR. So I remember years ago they were like, I was like, oh, cool, we do all these non-emergent transports for the local fire department.
Yeah.
And after so long, you realize, it's an abuse of the system.
Yes.
And there's a lot of things I recognize. I'm like, why are we doing this? You're gonna wait 30 minutes for us to get there. You could have transported this patient 2 blocks down the road, but instead they'll stand there and wait for us.
Yeah. I feel like that was one of the things I recognize, even working for a small company. I mean, the company I worked for, it was owned by a local proprietor.
Yeah.
It got sold to a board of investors.
Mhm.
It was, and has since been bought back by a semi-local proprietor who's kind of a mogul at this point in the EMS world in Ohio. But it's yeah, no, just not realizing that, because I thought it was so cool. Like, oh, hey, we do the primary,
Mhm.
well, secondary, because we weren't the first ones, but for the city. And it's
Yeah.
like, oh man, that's so cool. Looking back on now, I kind of look back with maybe a little more jaded, but also a little bit more honest with myself, like what it was. It was an abuse of emergency services. It is a waste of emergency services.
Yeah.
Waste.
It absolutely is, because when you're getting called out for the same person week after week for the same thing over, and you're just going to different hospitals at this point, like, why are we still doing this?
Yeah.
But I get you're there to provide a service, whether it's BS or it's not, because you're going to take that one time it's not BS, and you're going to play it off as it's just BS, and then you're going to be in trouble.
Well, and I think that
and I've seen that.
Yes. Well, and I think that contributes to the burnout level in private ambulance.
Yes.
Because you take ALS units out, and I know the few companies we have in our area try not to do this, at least in practice or on paper, they try not to do this. But taking an ALS unit out of service to go run a doctor's office training. I remember when I worked for a private ambulance company, that was actually what did me in most whenever I got my paramedic card, was that I don't want to be an ALS truck going to and from dialysis, going to and from doctor's appointments, sitting on hospital walls while they're getting an MRI CAT scan for the 8th time. Like that is, it burns you out because you're wasting your skills.
Yes.
You're not really contributing anything.
Yeah, and some of these companies, that's all they do is doctor's office.
Yes.
MRI, CT scans, PET scans, dialysis. I didn't do much of those when I worked for AM. Very, very few and far in between. There was one lady we transported all the time that was going to dialysis, but didn't get her every day.
We did a lot of dialysis.
Yeah.
Exhausting.
When I was on a BLS truck for AMR, oh yeah, you bet your derriere you were going to do dialysis, and I hated it because, like you said, you just let your skills go to waste. Because like, why? Or what they would do is they would split you and your partner up, take you off the road, not put you're a wheelchair driver for the rest of the day. I'm like, I am an EMT. This is stupid. We can just do this in the ambulance.
Yeah.
Like, come on. Like, the place I'm at now, I know how some people feel about private ambulance companies. They think they're Tommy Tough Nuts and blah, blah, blah. We have a very, very aggressive protocol.
Yeah.
And they expect you to do your job. They give you the tools to do your job and more. And it's like, why didn't you do this, this, and this? Well, why would I? Well, we give you the tools. We expect you to do your job.
We're paying you to do this.
Yes.
Do it. I think so. This is actually an interesting thing. So when I got into emergency medicine in general as an EMT, and then again as paramedic, you hear of all these things. And in fact, like when you watch most of the training videos and whatnot, they're not fire departments running the emergency calls. Private ambulance company running the calls. Like even if you, I can't remember what I think it's Fire Rescue 1. half of those, like, so they do showcase a lot of fire departments on there,
Mm-hmm.
but they also showcase a lot of do we need to take for a second? Oh, did you have
Birthday present from our chief.
Oh, that was nice of her.
Found out that the cluster gummies.
You're a nerd.
Well, no, the red dye is made out of parasitic insects.
Oh,
yeah.
ugh.
So you're literally eating insects. Pretty cool. They're delicious. Anyway, back on track.
Yeah.
Fire rescue one, and
So,
like you said,
so they, a lot of times they showcase fire departments, but other ones too. Like they showcase, it's not a fire department that's doing the medical transport stuff. It's a private ambulance company. And whenever I was in school, people were talking about, being on a private ambulance company. We're talking about emergency medicine from a fire department standpoint, and in a municipality, you're talking about from, oh, I work for this company here, and we were running all the emergency calls.
Yeah.
For a city, because back 25 years ago, 30 years ago, a lot of cities, they didn't run EMS, they ran just fire.
Yeah.
There's
still a lot of places like that, and it's they have their EMS, but they're still separate.
Yeah.
I mean, look out west too. Like California was a big one.
Yeah.
They used AMR a lot, and some places out there still do. Down in Florida, still use AMR, especially Broward County, and sometimes Miami.
I was gonna say a lot of the South in general, it's separate.
Yeah, Rural Metro was a really big one, but they also have their own fire department out west, up northwest too.
Yes. So, but it's whenever you hear those stories, those war stories, like, oh man, we got to do this, or the AMR guys who worked in Youngstown, or
yeah,
it's like, or what was it? It was the KNG or KNI?
KLG.
KLG.
Yeah. Still around, by the way.
So, but they're running primary stuff and shootings and whatnot for Youngstown, and then you get into it and you're like, I thought I was gonna do shoot. I thought I was gonna be doing like a true emergency stuff. I remember when I first got hired on my first big private ambulance company. Yeah. That's how I was introduced. Oh, so we're outside of this city here, and we're gonna, we are primary to them. They call us for all kinds of stuff. I'm thinking, oh boy, here I am, AMT. Let's go. And next thing you know, it's like you're doing hospital discharges. You're doing, grandma needs to go to her doctor's appointment, or grandpa has blood work. They're abnormal labs, which, I mean, we get those too, but I mean, they're abnormal labs that we drew a day and a half ago. Needs to go to the hospital now. It's like,
and I was that person when I first started working for AMR. I'm like, oh, cool, working alongside with this very busy fire department. Did not last long. I'm like, I'm over this. And I switched stations, and ran the primary / secondary for that city's fire department, because at that point in time, they may have had one ambulance open, if not zero.
Yeah.
And you're using AMR and 2-3 other different companies.
Yeah.
And I did learn very quickly that they would pick and choose their calls. And I'm like, I'm sorry, you're what? And they're all right here in the local hospital eating lunch.
Yeah.
And they just say, go ahead and next rotation, please.
Yeah.
I'm like, sir, you have an ambulance sitting right out there. That's what destroyed me.
Yeah. Well, and I mean, that still happens. Not yet. When you have a med unit for a major city that's running 14, 15, 18 calls a day, even 12 calls a day, 10 calls, I get it. That's exhausting.
Oh, absolutely.
You're getting your dick kicked in every single day. I get that. I get you need to get a break somewhere. What kills me, and it kills me in the position I am now with the fire department, but then also too with when I work for private ambulance, is that if there was a shooting or a stabbing or it's a MVA or something, those guys clear from the hospital like that.
Oh, absolutely.
They were gone. They're like, oh man, we gotta go do this. This is gonna be awesome. But if it comes in as general weakness or not feeling well,
or a psych issue,
especially. Oh man, we're not available. We're not available. I mean, department I work for, that's how we handle a lot of them. is that if it's not life threatening, we're not breaking, especially if we have a unit already out of service on call, we're not going to release another unit to go your run your BS stuff that you
Yeah.
just don't want to make. You just don't want to, and it's I hate that that you have to say it that way. That's what it is. It's like it's the stuff that's not cool and not flashy that you really don't want to deal with. Well, it all comes in the same group.
Yeah.
It really does.
Now, I will say, did I learn a lot?
Mhm.
Absolutely, I did.
Yes.
Especially when I switched stations and
Mhm.
started getting into the more 911.
Yes.
I did learn. My partner at the time in the business, very freaking long time. He was a chief on him. I don't remember,
Mhm.
but he taught me a lot.
Yeah.
I learned a lot from him. So I will say that you can learn a lot from these places. And you're just doing, going to dialysis or your doctor's point. You're not going to learn nothing. You're a glorified medical taxi.
So I'm gonna asterisk that for a second with this that you can absolutely learn a lot, but it's you're going to you're going to learn you're not going to learn how to necessarily use your skills as you are how to deal with people, just deal with people.
Yeah.
Which that's I mean, let's be honest, that especially in the fire side, that is a huge thing. Is just dealing with people and dealing
Oh yeah.
with people who you piss off because you tell them, hey, I can't go to that hospital, even that, and it's like, and you can't. But they're like, even though they're like, oh no, I have to go to this hospital. It's like, oh, I'm not driving you. I'm sorry.
Yeah.
We'll take you as far as Akron, but that's I'm not where we keep. There's no way we can go up to Cleveland.
Yeah.
Absolutely 0% chance.
A couple years ago, I had some lady wanted us to transfer her mom all the way up to Cleveland Clinic, Maine.
Mhm.
I said, we don't go that far.
No.
And she was not happy. I was like, we can go to Akron General.
Yeah.
Or that's as close as to the clinic you're gonna get, or
Yeah.
Medina.
Yeah. No, it teaches you how to deal with it. One of the other things, and this actually bit me a lot when I worked for private ambulance, was as EMT, you have if you're not comfortable with your skill sets, as I bump the thing trying to reorganize myself here, it can put you in a really bad spot, especially in a facility transfer.
Yes.
You're going from one hospital to another. You're going from a step down unit to, or a CCU to a step down unit to something like, because that bit me several times as a young EMT with only a year or two of experience, and you're being given a patient who could become potentially unstable. Not only being able to stand your ground and say, hey, no, this needs to be an ALS unit that transports this, but then also being able to say, okay, I know what to do if this patient crashes. And I mean, and that happened to me where we had a patient came from a CCU going down to a step down unit, and we were told like, oh yeah, she's fine on 6 liters of oxygen, and she was not. She was on BiPAP still whenever we went and picked her up, and it's like okay, we can't run BiPAP. We don't have that ability. We're not, and I was told to go pound salt by one of our managers, like that's like, oh no, you guys can transport this. I'm sorry,
No,
and they gave
can't.
you so much trouble because the doc gave us like, okay, well maybe we can be on 6 liters of oxygen. Immediately went from just barely holding on to like she was comfortable. If you didn't touch her, she was fine. To as soon as that BiPAP mask came off, immediately we were on the clock.
Got
we
a
were
story
on borrowed
about
time.
That. It happened to me recently.
Mm-hmm.
Same situation. They told our dispatch they were on high flow cannula. Okay, I can work with that.
Mm-hmm.
Yeah, she was not on a cannula. It was on BiPAP. And I was standing there, and she's like, I have to have this on at all times. Like, it does not come off.
Yeah.
And I'm like, I think I should be taking this.
Yeah.
My mind, and I'm contemplating. And it was out of an ICU.
Mm-hmm.
And I'm like, I told her, it's like, I can't use this machine.
Yeah.
And she's like, well, I only live it. I was like, I understand that, but if something happens, I can't touch this.
Yeah.
Like, I can put you on CPAP or a non-rebreather, and that's as far as I can go.
Mm-hmm.
After I said, let's just take her.
Mhm.
Now, mind you, she's also like 500 pounds.
Yeah.
Going home to a trailer.
Yeah.
Like, she did fine. She knew how to operate the machine.
Mm-hmm.
So I said, I'll just leave it on there. So I called my supervisor. And they're like, should never. I was like, I know. You can yell at me. He's like, no. He's like, you did fine. But the hospital should know better.
Yeah.
I'm like, I agreed, but we were told, cannula, high flow. Oh, no. They just said that because they know they can get a BLS unit quicker than an ALS truck. Mm-hmm. And that's where there's a problem in the hospital systems as well.
Yes.
And I see it constantly.
Well, so I don't know if you remember this. You should. You've been in long enough. So when I worked private ambulance, 2016-ish. Oh boy. 2016 was the big push for all the Medicare, Medicaid payment stuff. You could no longer put on the ambulance transfer sheet.
Yeah, the PCSs.
Yes. Yeah, you could no longer put on their general weakness or can't sit
non-ambulatory.
Yes. Like, and I mean, now that was nothing necessarily new. It was something that, like, for 10 years. I remember telling a nurse once, I took it back. She said, I've been doing this for 10 years. And it was never a problem. I looked at her and said, just because you've been doing it wrong for 10 years doesn't make it right. Still sounds like me now.
But here's the thing, though. That's still a problem today.
Oh, I can only imagine.
It's bad.
Yeah.
It's very bad. And I will specifically say, I need medical diagnosis, medical reasons why they need to go in an ambulance on a stretcher.
Yes.
And not in a wheelchair or a private vehicle.
It has to be one of the what was it 3.7 codes, three digit dot whatever codes.
Well, I mean, and I'm like, what's his medical reason? Diagnosis. Well, I don't know. What do you mean you don't? You've had him for almost a week.
How could
open his chart? It's like, I will help you. And I get yelled at, and she puts down non-ambulatory. I'm sorry, that's unacceptable. Can't do that.
Yeah.
And she writes down difficulty breathing. I was like, that's not a medical reason why he needs an ambulance.
People walk around all the time difficulty breathing.
I said, is he not? Why is he non-ambulatory? Does he have deficits from a stroke? Oh yeah, okay. Put down CVA second slash left-sided deficits. Mm-hmm. Done. And I got criticized by this nurse because she's probably been doing this close to 30 years.
Yeah.
And she's like, nobody else is like, I don't want to get in trouble for this. He doesn't want to get this bill.
Yeah.
I'm like, because it will come to you guys first, him second. And I'm going to get yelled at why I didn't make sure this was done correctly. Half the time we don't even get them filled out.
Oh no, I remember for a while there, we were just getting it. And it was just, it didn't even have like our company, the company
name.
On top.
Yeah.
It just had private ambulance service. Oh, you guys can fill that in later. It's like, no, we can't actually. It's like, well, it didn't give like a destination address. Like, no, you have to put this. Oh, well, I put down the name of the place. No. You have to put down, you know how many Bethany Health Cares or Bethany Care Centers there are in the state of Ohio? There's like a dozen. Like
quite a few out by where you work too.
Yes. Like if you go to a place, like there's several places called New Destiny.
Yes.
Like how many places?
Alter Cares.
Yes. It's like you have to be more specific.
Yeah.
It's like otherwise we're just arbitrarily taking people arbitrary places. Now it boggled my mind, but then I realized too that this is a system that we created because we have a whole group of people who are really too unstable to go by a private vehicle, but they're not stable. They're not unstable enough to go by ambulance, and we can't kick them to the curb. They can't afford to or not a candidate to go to a nursing home. So what do you do with them? And we've kind of created this gray middle ground where. And then it puts other people in the middle, or in the middle of that. It puts EMTs, young EMTs of that, in the middle of this crazy sandwich. That just like, what do you do with it?
And I see that not much anymore since we lost one of our. Well, I wouldn't say lost since we quit doing one of our contracts.
Yeah.
one of the biggest one was one of the freestanding ERs in between you and Akron.
Yeah.
A lot of time was, I'm like, 23 years old. They have a flu. Why are we admitting them? First off,
Yeah.
give them some antibiotics,
Yeah.
some meds, whatever. Send them home. Why are we admitting a healthy 23-year-old?
Yeah.
Like, this makes no sense.
Yeah.
Or they're like, oh, we were going to send them by private vehicle, but figured they'd get in faster if we just transferred them. Are you kidding me?
Well, that's the other thing too. Is like
silly stuff.
I remember how many times we went and did those kinds of like freestanding ERs or boo boo centers or whatever. As like the person looking like I can drive myself. And sometimes you have to be a patient advocate to say, why can't they? What? Oh, well, we don't feel okay. They can sign off AMA and go.
Like, I get they're gonna have to start the process all over again.
Yes.
I understand that. But there's no reason for them to go by ambulance at all. And I actually had a doctor at that facility stand up to another doctor, and I heard them getting the older doctor yell at this younger doctor. And he's like, I am doctor. I've been doing this for 40 years. You don't know your head from your ass. And I'm like, are you kidding me? This man is 18 years old.
Yeah.
He had a tooth abscess, and we're admitting him for.
Send him to a dentist, get drained.
Exactly.
Look, if Fort Knox can take care of an infected tooth that should be wisdom teeth coming out, but Fort Knox can take care of it, and I survived. I'm pretty sure a civilian dentist can handle it.
It's just
fine.
In a way, I'm glad we don't deal with them anymore, because that was the nonsense that they were admitting. I'm like, this is dumb.
Yeah.
This is a total waste of our resources, your time, the other hospital's time, their time.
Money.
Too. Yeah, that too. Like, the hospital we deal with now where I work at, especially down more towards Central.
Yeah.
Stupid. They use us and abuse us constantly, and it's frustrating. But that's not going to change anytime soon.
No.
But the one hospital we're mainly taking out of, well, most of it is like, oh, we're just going back to a nursing home.
Yeah.
Okay, that's no big deal. They're short, easy trips. I'll do those all day.
Yeah.
But we do get a lot of high acuity traumas out there, because you're either flown or you're getting transferred out. That's it.
Yeah.
And you're either going 45 minutes up north, hour and a half north, or you're going an hour and a half south.
Yeah.
That's it.
Yeah, no, what kills me is that it's no matter what, you're getting an extra expense, an extra bit into that too.
Yeah. It's
like, and I realized, okay, so from the standpoint of, if you're unstable yet, you're going to the closest facility that says EMERGENCY.
Yeah.
That's like that. You are going. I had to think they're how to spell it. Yeah, if you have those 7 letters on your building, I'm bringing them to you if they're unstable. If you don't like it, well, you take it down, because you are the best thing to do. Even if you only stabilize them so they can be transferred, that's fine.
And sometimes that's what you need to do. You're the closest to the facility. They need stabilized, especially if they're going for a longer distance trip. Some of these places that take these patients into them, where they should be going to the correct facility, extra 4 or 5 minutes up the road. Shame on you for doing that. First off, I see that all the time. I'm like, why?
Yeah.
Why are you doing this? Drive an extra couple more minutes, take them to the appropriate facility.
But then the other side too. So let's say, did you get somebody or something out there, mild asthma attack? Okay, mild asthma attack. It's that time of year. We got a lot of dust, and not so much pollen, but dust from like people grinding up leaves, burning leaves, that kind of thing. And so they necessarily need admitted. Like, one of the first questions that I learned as a paramedic, we asked somebody who's having COPD, exasperation.
Have you been admitted for this?
Have you been admitted for this? And have you been intubated? Because that's going to tell me, okay, how far down this rabbit hole can we potentially go in the next 20 minutes?
Yeah.
And most people I come across, no, it's usually, I'm okay. It's just in this moment I can't catch my breath.
Yeah.
And a lot of times, like we get them over that hump that by the time they're at the hospital, yeah, there's still need some steroids for a little bit longer term care. They don't necessarily need it admitted so much as okay, we need to monitor for another couple hours,
Yeah.
another 4 or 5 hours, and maybe prescribe some steroids for next week or next couple weeks because hey, your neighbor's out there grinding up his leaves, or you've been having right now where I live, we've been having trees cut down left and right. That's a lot of dust to get kicked out from those chippers. And a lot of, if you live in those immediate areas, you can smell the chainsaws, you can smell those diesel trucks. Hey, you might need a couple weeks of corticosteroids to help get you over that hump because you're gonna be in the same boat. You don't need admitted for that. You don't need that $8,000, $10,000, $12,000 hospital bill to be admitted for it. You just need something to help you along.
Yeah.
And that's the other half of it. It's like just because they come into a hospital does not mean they have to go.
Yeah.
Like we've been running into this problem when it comes to like code ones stuff, that just because you called 911, and a lot of times it's family members who call 911, doesn't mean you have to go to the hospital. And I remind people of that, especially car accidents. You get a little fender bender and someone's like, oh man, I'm a little, well, hey, we can check you out, but you don't have to go by us. Especially once they're like, well, I'm not sure if I need to go to the hospital. Like,
Yeah, I'm with you on that. I was like, we'll check you out, and then after we're done, everything's checking. It's like, we don't see nothing wrong, but we don't have X-ray vision, we don't have a mobile MRI. It's never a bad idea to get checked out. If you want to go later, just take yourself. You
don't have to. And it's like, it's what this asterisk of saying what you just said there. Hey, we can't find everything. There's we can't do X-rays. We can't we can't do MRIs.
We don't do blood work. We don't have a lab.
Like same thing as like with you get somebody who's got chest pain, and like I will always tell them, like, okay, I don't see anything on the monitor, but
doesn't mean there's something.
Yeah, that's
your cardiac enzymes can be elevated. We don't know that until you get that blood work.
Yep. And I'm very cautious about somebody saying, oh, hey, I don't, like, even if they say I want to go to the hospital, like, you need to do something. Chest pain is never by itself a benign sign. It's always linked to something.
Yes.
So you should take that at least somewhat seriously. But this is the problem, though, is that we don't do this in the hospital transfer. We don't do this private EMS world. Everything is balls to the wall, go, 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 go. It's everything gets the same acuity as a stroke. Everything gets the same acuity as the STEMI.
I mean, like the place I work for, even our med director, he used to be a combat medic in the Army.
Yep.
They paid for his medic school or his med school, and now he's a med director for one of the biggest hospital systems in the state of Ohio.
Yeah.
Man, he's very knowledgeable. He's very pro EMS. He expects us to do our job, especially the EMTs.
Yes.
He's like, just like one of our old coworkers said, you're not just an EMT basic. You are the backbone.
Yes.
And a lot of people need to hear that. You're not just a basic. You are the backbone.
Especially, I would even say especially in the private ambulance, because one thing, because the term paragod is very much a private ambulance term.
Yes.
Does it apply to firefighters? Absolutely.
Oh, yeah.
But it is very much a private ambulance term.
Yep.
Because it's the paramedic who thinks that they are greater than life. They are bigger than life.
Yeah. And a lot of them, in my career in private EMS, are very, very lazy.
Yeah. There's some very good medics out there.
Oh, absolutely.
But there's ones who also, you do get the ones like, I remember when I was working in private ambulance, I was actually doing some of my ride time for paramedic school too, and said we want a stroke, and we had just gone over stroke class. I'm like, hey, you should do a 12 week. Why? Because cardiac issues such as AFib, new onset AFib that can throw clots, can be a precursor to a stroke. Makes sense, because when you think about it, if you got AFib, you're not pumping your blood effectively. You're trying to figure out, well, how does stroke start?
Right.
Oh, hey, you're throwing clots because your blood's not circulating.
Exactly.
So anyways, we go on this call out in the boonies, and we get there, and guys definitely have a stroke. He's having clear signs, fast stroke. And I suggest before transport, hey, maybe we should get a 12 lead. He's also got a cardiac history too. Well, and the med goes, what's like, oh well, this is a stroke, we'll put him on 4 lead, but it's like, we don't really need. And then afterwards, like, he comes back and says, you know what, actually, we're actually kind of on something there. The more I thought about it, more I thought, like, no, he's candidate for other issues, other cardiac issues
Right.
aside from that.
And and what's a 12 lead gonna hurt? It's not invasive.
Nope.
And you can hey, 12 lead checks out fine. You can check that off your list too.
So and I understand, like, okay, so we want to be quick and be expeditious when it comes to strokes and things like that.
You also
Traumas
need to
too.
be thorough too.
Yes, and here's the thing: it's like, so unless how do I say this carefully? Extra 2 minutes it takes for you to do a 12 lead on a patient.
Mhm.
That's putting the stickers on and everything. And really, it's even less than that because you should have them all right on board as part of your baseline. But the extra 2 minutes you do that is not, in the grand scheme of things, going to make a huge difference in the treatment plan, whether they're inside or outside that window.
That was a perfect example because the call I went on yesterday came in as general weakness. Said they were left arm was kind of numb. Okay, so we started thinking cardiac.
Yeah.
But the daughter's like, she's been very weak on that left side. Now my wheels are turning, so we get her in back of the squad. I did a quick stroke assessment on her. Did have left side weakness on her grips.
Yeah.
And for a moment, she did have some facial droop on the left side too. And then a couple minutes later, we did it again. And my partner at the time noticed the same thing, the left side of weakness, but the facial droop resolved.
Yeah.
Okay. Are we having a TIA now? What's going on? But we still did a 12 lead.
Which, again, though, TIAs they indicate something.
Yes.
They're indicative of something.
Yeah.
But again, though, too, when you're ruling things out, because we have one here where the guy was having both. He was having a STEMI and a stroke at the same time.
I think me and you were on that one.
No, you weren't. No, you weren't.
No,
this was me, Chief, and Mike.
Okay.
We were on that one. It was just stumping us because, like, what is going on? Like, this guy is unstable as all get out. What is going on? And it turns out he's having both. Again, especially whenever you start getting some of these things that, like, your neuropathies. Your neuropathies mask a lot of other signs and symptoms. This is why you get your blood sugar people. You should be doing a 4-lead, 12 lead on them still too, because all those things, they all run together.
Yeah.
They all start to affect each other and mask each other. So,
and one thing I always been told, like, paramedics, when they get calls, they're thinking paramedic level.
Yes.
You have to start at the basic and then progress. Because he also told me, as a medic, you're thinking the worst case scenario.
Yes.
You thinking this. Start simple. Just like checking a blood sugar. That could be the main reason right there. I have learned over the years that is very, very highly missed.
Yes.
Blood sugar.
Yes.
Like, was it a couple weeks ago? One of the departments out by where I work went on an unresponsive CPR in progress. His blood sugar was 10.
I wonder why they're unresponsive.
No kidding.
I couldn't imagine.
Now this poor man's got, broken ribs and everything else. He was still breathing.
Yeah.
It was a bystander that was doing CPR.
Yeah.
They didn't know he's diabetic, but why didn't that department? Oh, let's check his sugar. They put him on a Lucas device. Never once checked the sugar. So they got to the hospital.
Yep. Well, and so this kind of goes into the what do we do about this? Because this is this phase of the show that's like I'm trying to push now. I mean, just not like we'll take that for example. So, like, what can you do to prevent that from happening? First of all, I don't think we have to do anything groundbreaking. We don't need to have a big sit down powwow.
No.
Okay, everybody. So we're gonna realign how we do it from an individual basis. As you said, thinking basic stuff first. Okay, so you got CPR going. Cool. We're going to keep CPR going until proven otherwise.
Yep.
But we still need to do a thorough everything else H's and T's assessment.
Absolutely.
You're running everything, especially if your monitor is showing something that's like that's not a shockable rhythm, not VFib, not VTAC, it's asystole, PA, or otherwise, yeah, you should definitely be saying, okay, what other causes that are there?
Yeah.
Like that's the sugar should not be the last thing. So it's just being able to say, hey, what can how can we like realign ourselves without like completely turning the whole world upside down to say what's basic.
Exactly. I will give a good example. Probably about 6 months ago, my partner and I was sent out to a nursing home, because the patient was very lethargic.
Yep.
And we found out, she had some surgery done on her belly and stuff like that. And now she's very lethargic.
So she's septic.
Absolutely. So, but hold on, it gets.
Yep.
Was it Billy Mays? But wait, there's more.
Uh-huh.
OxyClean, man. She's getting report for a nurse. I'm in there talking to her. Okay. She's lethargic. She's like no times 1, maybe 2.
Yeah.
But also noticing she's doing one of these.
You think?
Yeah. And so I'm like watching it, and by the time my partner got in there, she was just rapidly decline, and then lips started turning blue, face she was very ashy. I'm like, my partner goes, Jay, and now she's just silent seizure. I'm like, she's not breathing. And first thing we did, blood sugar.
Yep.
Even though we knew she wasn't breathing, but I went straight to the blood sugar.
Yeah.
Got the pads on her. Blood sugar was great, but she was done.
Yeah.
We got Ross within 5 minutes.
Yeah.
Because we were right there. But right there, okay, if it was a blood sugar, we can kind of fix that.
Yeah.
But we had to call 911 because there's not much my partner can do. She's just an advance.
Yeah.
We don't take a whole jump bag. We take a monitor, glucose monitor, and that's it.
Yeah.
We don't take. Technically, it's a 911 call.
It turned into a 911 call.
Oh, big time. But we weren't expecting that either.
No.
But if we were to had her in the back of the ambulance when that happened, we would have never called 911 because we were going 2 miles up the road.
Well, and so now this brings the next thing that like they can help with the. So if you're EMT or paramedic, any level in private ambulance, don't forget your index of suspicion whenever you go on these air facility transports. Talk about some of the fringe cases where it's like, hey, you got a really bad patient that was kind of already known to be a bad patient and just kind of got slighted in. One of the more subtle ones, so we were doing dialysis transport one morning, and it's, zero dark stupid, and we're going to the dialysis clinic, and we've been on this particular patient, several times. What you do is basic carb, your dialysis. So had the wherewithal to say, hey, we know how they should be acting. We knew a difference between their, hey, I didn't have a good night, and no, they're truly sick.
Yes.
And that was this case here that just happened to say, hey, something's not quite right. We took blood pressure and their blood pressure had bombed out. It wasn't anything like terrible, like in my memory. Like my immediate memory, I'm like, oh my gosh, they were dying. It wasn't that bad, but it was like they were sub 100s over 50s for their over 50s, over 60s for their blood pressure. And their pulse rate is up in the low 100s.
But like that's not normal for them.
Exactly.
You've been with them long enough.
And even if I hadn't been with them, that's looking at that saying, that's no, something's not right here. Those two things together, one of them isolated, I might let go.
Yeah.
Maybe not pulse rate anymore, but even so, like one of those isolated, okay, a little bit elevated pulse, like into the high 90s, low 100s, but blood pressure's good. Okay, I'm a little more inclined. And vice versa. Blood pressure is not great, but the pulse rate's more or less normal. Okay. Both those things combined. So, just keeping an open mind, index of suspicion that, hey, these are still, if you are being transporting people by ambulance, just pay attention to like how they're responding, because how somebody should respond.
Yeah.
Generally. Even sick, how they should respond.
Oh, absolutely. I remember years ago, one of these fire departments brought in a patient. I don't exactly remember before, but they're like, oh yeah, it was a BS call, blah blah blah. They had a monitor on the back of the cot.
Yeah.
turn 12 leads still connected to them, but turned off. Well, in the meantime, when that patient was sometimes being transported and being taken to the hospital, passed away. When they moved him over to the bed, they're like, the nurse goes, it's dead. That does not look good.
No.
Just because it's that BS call. You put them on the monitor, leave them on there.
Yeah.
Because I don't want that on me. Like,
well,
I wouldn't know what to do. I'd probably quit everything right then and there.
Right. No, I mean, there comes a point where it's like, okay, and this is why I'm very like, I don't like downgrading calls very much. I did the other day.
Yes.
But it's okay. Mid-40s person who's generally healthy, who is involved in the fender bender, is a little different than grandma who's, who's feeling a little sick and feeling a little ill, who I put on 4-week. Very, very different ends of the spectrum there. But it's like, if you put someone on 4-week, and I know our med director has said this, if you felt the need that they need to go on the 4-week or God forbid the 12-week, ALS should probably stay in the back with them. There was something that was indicating to you that they needed that level of care. You should probably have ALS, and you should probably get. Just got through that. I mean, but I'm being serious because I've seen a lot of megs in my time. Thankfully, not where I work now, but I've seen a lot of megs in my time. Throw them on the 4-week for enough time to get the 6 to 10 second strip. I'm like, okay, they're good. Go ahead, take them off. No. It's in the name. It's in the name. 4-week monitoring. 4-week. It's in the name. You put them on and you leave it on. You don't take it off until you're ready to transfer care.
Exactly.
Like, so just
I see that in a lot of private EMS too. They'll get the call like, oh, they're on the cardiac monitor.
Yep.
They'll put them on there enough to get their stuff, and it's to the point now we are doing bedside to bedside.
Yep.
Because our supervisor, they got tired of people doing quote Jesus vitals.
Yep.
120 over 70, 120 constantly.
Yep.
Everybody's got 16 respirations. Everybody's pulse is between 60 and 70. Not everybody. Sorry. There's no freaking way.
No.
So I get that, because I tell a lot of our new hires when we're FTOing them, these are legal documents.
Yes.
Something happens and they pull these records and you have to go to court. They're going to ask you questions. They are up there to make you look incredible.
Yeah. Well, and it's one of those things too, that if you go from a patient who was quote unquote stable and then magically unstable and you didn't catch it. Now it's one thing if you caught it there, but if they went and all of a sudden and you transfer over and you said, oh, the entire time their blood pressure has been 118 over 64 and they've been sitting pulse rate of 68, breathe in 12 times per minute and 97% room air, and you transfer them over and their GCS of 3 and their blood pressure is 90 over palp and heart rate is 115. Yeah, I get that something could have happened in there. But first of all, generally speaking, that is not a light switch moment. I see very few light switch moments where it's like 1 minute they're talking, the next minute they're not.
Yes.
I can only think of one in my career where that happened. And looking back on it, too, it was the typical, I'm hypoxic, I'm ripping off my oxygen. We didn't recognize it as that in the moment, but that's what she was doing. She was ripping off her own oxygen because she thought that it was hindering her. But that's the only one I can think of. Everything else is like, if you took your vital signs, you can generally see a gradual decrease.
Yeah.
Over time. So that tells me there that like as you call it, your Jesus vitals, like that, it's not that hard to catch those things, and it's not that hard to actually explain away things on your report. if you do it properly. But anyone can clearly see when you faked it.
Oh, absolutely. And like I said, I told these are legal documents. You get up on the stand, that attorney is going to make you look stupid.
Yeah.
Big time.
Especially if you
and then
if you
your
faked
career
it.
is over.
Yeah. It's like, I hate to say, it's like you could tell when somebody made something up.
Yeah.
Like it's like it's not like saying, oh, hey, okay, hey, I can bridge the gap. I have two sets of vials that are 25 minutes apart, 140 over 90, 140 over 74. Okay, I can bridge them between, like, okay, their blood pressure's here. That's one thing. Being able to say, yeah, because you have two trends. But if you had one blood pressure that was, oh, they're 160 over 80.
Yeah.
Just throw a number there. And then the next blood pressure you took 35 minutes later is 92 over 40. There's a disconnect there.
Yes.
There's something there that you did not, and you can't go back and say, oh, well, they just became like that. Like, just became like that as in you just realized they became that way, or they just became that way as in while you're talking to them.
You know, like you, like I can think of one instance in my career, and it was freaking private too. You get called for one hospital, we go and transfer to another hospital. They called it an NSTEMI. Oh, by the time we got him moved over,
there was no end left.
Oh, he was having a full blown.
That's what I'm saying. There's no end left. There's no end.
It is STEMI in bold, capital, underline, italicized. He became very diaphoretic, very pale, cool, clammy. And we printed a strip out and showed it to the doc. He was like, I will call the hospital and let them know too that he needs to go straight to the cath lab.
Yep.
And the entire way over there, he was saying, please don't let me die.
Yeah.
And I'm like, this dude's going to arrest on us in the back. And he almost arrested on the cath lab table.
But again, that didn't just happen.
No.
Like, but if it just happened, I would start asking myself, so what was happening that this just happened? It's just like whenever we get our patients who say, oh, well, this just suddenly started. Just suddenly started? Okay. Like suddenly started as in you were walking and suddenly started? Or
what were you doing when this started?
Yeah. Or that you've been noticing this for like 4 days, but then you did something that like exasperated.
This is what I tell a lot of new hires too. We are human detectives.
Yes.
You're the detective. You need to figure out what's going on with them. What started this? Everything. You got to ask questions.
Yes.
You got your subjective and your objectives.
Yes.
Figure it out.
Yes.
Then you might have a couple different scenarios in your head. It might be this, or this. Keep asking those questions. If you have to, reference your protocol book. There is nothing wrong with that. I don't know that protocol book by the back of my head, and both you and I both are on 2 protocols.
What was it I kept on saying the other night? CE is like, well, what are you gonna do?
Reference my protocol, especially with peds.
And I'm not just saying that because my medical director's sitting on the opposite side of the room. I'm saying that because literally, I'm not memorizing these numbers. That's not a good way to operate with peds. I'm gonna look.
Unless you have a photographic memory, even then you should need to reference.
When people say, "Oh, I can remember,"
one of my old supervisors was like that. He had a photographic memory. Mm-hmm. Yes, very, very, very smart. Yeah. I don't know why he's not a doctor or some kind of surgeon, but EMS is what he loves. Yeah, but he can reference you times 200 years ago. Yeah, that's how smart this man is. But I'm like, okay, but he's like, but there's nothing wrong with going to your protocol book. I still go just to verify it.
Well, and so here's the thing: it's like you should get good at asking questions, and then also calling and bouncing ideas off of people.
Yeah.
So my boss at work, he and I, we don't always see eye to eye. He and I are on 2 very opposite ends of the spectrum. I am one who will trust but verify. He is one who, if you're asking questions, you don't know what you're doing. And what's funny,
very old school way.
And it's funny because we're about the same age.
Really?
Actually, I'm a little older than he is. Wow. But I know I drive him nuts because I will call and ask him borderline stupid questions on the most mundane thing. Not because I'm trying to be a smartass, but because I'm looking at this and saying, okay, I just want to run by, this is what I'm seeing. Does this make sense what I'm about to do? Like, and I do that with a lot of stuff. But as you said, you got to be good detectives, but also have a group of people or a list of numbers, you can call, say, hey, or you're calling to the next hospital. I've done this countless times. Hey, here's what I'm bringing in. I want a second look at this.
Yeah.
Can somebody take a second set of eyes? I think I'm seeing this, but can you give me some clarification?
I mean, years ago, when I was working nights, we went to a nursing facility to take a patient because she was going to get a blood transfusion.
Yeah.
Okay, it's your simple run of the mill call, basic BLS call. Going through your hospital, get your transfusion. No big deal.
This chair's kicking my ass in the moment.
And like, failure on my part, I should have asked the nurse, hey, what was her last set of eyes?
Yeah.
And I know better, but I'm sure I was also at that point.
Yeah.
Because, working nights sucks.
Yes.
Well, en route, I'm like, blood pressure is through the roof. She had her blood pressure left. Now, mind you, it's like 250 systolic.
Yeah.
So I switched arms, after I did 2 sets, and it's still in the 200 systolic.
Yeah.
My partner at the time, you know her too. I said, hey, this is her blood pressure. I've done it 4 times, and I've done a manual and still got the same thing.
Yeah.
I'm calling the hospital to see what they want.
Yeah.
And so I called, and I was like, hey, she's coming in for a blood transfusion, but this is her blood pressure consistently. I mean, Cincinnati stroke was negative, but something is going on. And they're like, come straight to the ER, and I need you guys to go ahead and upgrade her to code 3.
Yeah.
Yeah. Oh yeah, she had a stroke.
Hmm?
She was having a stroke.
Well,
Simple calls. And like, simple call in the ER. Hey, this is what I had. This is what she was going for. What do you want me to do? Is there, got a history of high blood pressure, but she's had her meds, and it's never been this high before.
Well, and so now you're hitting on something else. It's complacency, which this is one thing I know in the private ambulance world. I became complacent with a lot of things.
Oh yeah, I can't say that I haven't either.
Because it's like you see so much stable that you kind of forget that people can become unstable, or that subtle things like a person who's not able to lift their right foot or left foot, or this turns into story time between us. Honestly, when it's all said and done, we have patient ones who we went to do a stroke assessment because we stood them up and they almost fell over. And the only chief complaint was, I've just been feeling really weak. Their left foot, I was having to lift their feet. This is before we really got into the van and all the other stroke assessment stuff we do. I was having to lift his feet. He lifted his right foot, and you could literally count to 4, and then left foot caught up. Like all of a sudden, like it was the weirdest delay. On that, like, yeah, I think I have a stroke. Like it was just that moment, but it was such a subtle thing that the home health nurse and everyone else who'd been on this had missed. And yeah, when we got there, we got confirmation. No, it was definitely a stroke. He was having a stroke. Yeah, don't let complacency and that this person always calls for abdominal pain. It's nothing.
Like I said earlier, you'll get the same person calls over and over again for the same thing. It's that one time that it's something serious and you're not taking it serious.
Yep.
Use my language, shit's gonna hit the fan.
Yep.
And you're gonna be like, weren't like this when we were transporting them. But then you got some I see a lot in private too. You get those patients you constantly transport. They sit right there in the airway seat and they don't pay attention to them.
Yeah.
I'm like, okay, yeah, but that's that one time. Things are gonna happen. Like it happened to me not too long ago on Monday.
Yeah.
She was being discharged back to the nursing home. Got history of seizures since she was 4.
Yeah.
I walked in, I heard snoring. I thought she was sleeping. Oh no, she wasn't sleeping. She was seizing. She was foaming out the mouth.
That's up the lecticus, just gone.
Oh yeah. Oh, she's poor lady. Yeah. She's probably on hospice now. But
yeah. But again, your complacency. I've known plenty of people. I've worked with plenty of people, especially in the private ambulance side. It's like, oh, don't worry about that. They're fine. They're fine. Let's just get this. I'm like, no. Let's Yeah, it pisses me off too to be out over dinner or be out like when you're kind of funny. We were trying to get together for Thanksgiving dinner at work,
Hmm.
and we just kept on dropping call for
Yeah.
call to the point where even people were like, "Aren't you guys gonna try to have dinner?" Like, oh, trust me, we've been trying for about 3 hours.
Yeah,
We've been trying, and it's just not work. But that's just how it works
it
sometimes.
is.
You still have to give good care. You still have to be empathetic and sympathetic
Yes.
and understanding and pay attention.
Mhm.
Because sometimes you see something that's really subtle, like we hear all these stories through TikTok and YouTube and whatnot, and all like Instagram, like the dispatcher who somebody called to quote unquote order a pizza, and it's because they're calling because they're terrified and
Yeah.
they need police. But that's the kind of like not like necessarily so blown up. That's kind of awareness you need to have when
Yeah.
somebody's telling you, "Hey, this doesn't feel right and this is different." They're
You know,
probably not wrong.
and a lot of the times, the things that I see in private EMS
Mhm.
on my full time job, there, patients come and's like, listen, something doesn't feel
Yeah.
right. They don't find the doctor there. They say, oh, you're fine. There's nothing wrong.
Yeah.
Go home. And then they keep insisting, like, there's something wrong. I'm
Yeah.
telling you. Yeah, you can run all these labs and everything else, but they know themselves the best.
Yes.
That doctor doesn't. And that's happened before,
Mhm.
transferring from a hospital 45 minutes to another hospital. And the next thing you know, they're seizing in the back.
Yeah.
Never had histories of seizures, but they said something doesn't feel right.
Yes.
They knew something was wrong. The doctor's like, you're fine. You can
Yes.
go home. Like, and then he finally said, fine, I'll transfer you to another hospital. Just, he wanted them out of there.
Yeah.
He didn't want to deal with them no more.
Well, and how many whenever the private ambulance you get that it's like, oh, we're just doing another inner facility for somebody who I don't know why they're going. I've been guilty of that. Why do
Me
they
too.
have to go from here to the clinic? Why do they have to go all the way up to Metro? Why they gotta go down to Columbus? Is they're stable, they're fine. And it's like, well, maybe they look on the surface, but there's something underneath the saying, something's not right here.
Yep.
Something's missing. And
Absolutely.
you gotta keep that open.
And I try to tell that to people too. You have to be open minded. Really do. Just because, yeah, they're stable. They look stable. You can't see everything. Some of these hospitals doesn't have all the capabilities these big funded hospitals like Cleveland Clinic, UH,
Mhm.
Grant, OSU. They got was it OSU has one of the only gamma knives in the state of Ohio.
Yeah.
People go all over for that.
Mhm.
And that's a pretty cool
Yeah.
procedure.
Well, and last thing, and this should be probably a good place to land on because we're at an hour and 2 minutes as it is here. But is that don't become in private ambulance, especially if you're young, resist this as all you can. Don't become the paramedic or EMT who is going to quote unquote catch the faker.
Yes.
Like the person, and this kind of goes with the complacency thing too, but this is a totally different thing that I've worked with plenty of medics on both sides of the house too, both in the private sector and municipalities and fire departments. But there's always that one who's like, "Oh, I could tell they were faking," and usually it's armchair quarterback after the fact. "Oh, I knew they were faking." Like we found them in freaking bushes. Something here is not fake.
Yeah.
Something here is not fake. But don't a lot. I know a lot of medics I worked with in the private sector who that was the badge of honor. Did you reach the Valhalla of I can tell when somebody's making it up. I can tell when somebody doesn't really need to break that. Like
Yes.
I get there are people who don't. I get but that is not our decision to make. Is our decision to make like do we need to necessarily go full bore and they need 2 large bore IVs, 15 liters of oxygen, intubate, all that. But somebody calls me for emergency medical services, even if I think they're faking, does not mean that I don't do a good assessment on it.
Exactly.
Not
You
mean
don't
I
treat
don't
them
do
any
vitals.
different way.
Yeah. Like I might get a 18-year-old, 20-year-old who's like, "Oh, I got chest pain." They're still gonna get a 12 lead.
Yep.
It's not likely, but after exhausting everything else out, and they're saying I'm having crushing chest pain and it won't go away, and it just feels like somebody's sitting on my chest. You're getting a 4 lead and probably a 12 lead because you can still have SVT rhythms.
Yes.
With 20-year-olds.
I've actually taken I think he was 14 or 15 in SVT.
Yeah.
Well, I wouldn't say I didn't take them.
Yeah.
I had a call. I'm like, I cannot take this because they're in SVT. Their heart rate is 190 sitting on a bed for 2 hours.
Yeah.
I'm like, I cannot take this call.
So it's like, don't be
It
the one
can
trying to catch
happen.
the faker.
Yeah. But he was also a football player too.
Yeah.
He collapsed on the field too.
Yeah. Like, and I feel like this is kind of goes along with an old adage of just walk it off, or these kids today are just soft, or like, I feel like it goes with that. That like, I'm gonna be grumpy and like, oh, they were faking, they didn't need an ambulance, and there are those people out there
Oh,
who do
absolutely.
not need an ambulance. If you stub your finger, not need. I know one might.
I need one after my concussion today.
The answer is no.
I'm stuck here.
If you're a trauma, I'm thinking backboard C collar. I'm gonna put you on the vacuum mattress. We're gonna, we're gonna give you the whole 9 yards if you think you're a trauma. But no, it's you do so much of a disservice, because then you begin developing bad habits. You stop looking at things of like, okay, this could be a problem, and you start looking at people as they're becoming a burden to you.
Yeah, and when I first was getting into this, I'd probably say after 2 years, I've realized like some of the guys I've worked with, that's how they exactly feel. They've been burnt. They're burnt out from it.
Yeah.
And I'm glad I got away from that company. I did, because I was starting to feel the burnout.
Yeah.
Because, a lot of the stuff we were taking, they didn't need to go to the hospital. Especially when you pull up on scene and there's 10 cars in the driveway and all of a sudden nobody has a car or a driver's license.
Yeah.
I'm like, come on, like I know better, but fine. Well, I'll still treat you the same no matter what.
Hey, we're here.
But I was getting burnt out from that.
Yeah. Well, and it's not even just that it's that you get burned out there on one moment. It's the shifting of gears that, especially, I know we feel this on the primary side of like, you go from the guy who stubbed his toe bumping into a wall,
Yeah.
to grandma is having a major stroke, and like those are two polar opposites of thinking in emergency medicine. Like, and that shifting of gears is like grinding things, going from the 5 minutes ago you were just talking to the person, everything was perfectly fine, and now you're like, oh crap, we have to think 5 times faster. And you go from I can sit on scene and chat with the family for like 20 minutes and make sure I know what I'm doing and what I've got going, versus, okay, hey, give me a quick rundown, let's be thorough, but let's be quick, and we need to not sit on this play.
Yeah, absolutely. Like you said, we gotta stop being complacent.
Yeah.
That's the biggest kill, in my opinion. Complacency, and I would also go lazy. There is a lot of lazy. I see it with some of my coworkers. Like, that's just running no call, but anything can happen.
Well, and so now, kind of going into the management side, is kind of like, as manager, like, this is, and I brought this up earlier, we don't need to have major powwows every single time. We don't have to have this big sync session where we sit down and like, okay, we're gonna sense everything, and we do this in the military, and it drives me nuts. Something happens, we sit down, oh, we're gonna have a big sensing session, everyone sits down, have a kumbaya powwow, we're gonna talk, and it's like, no, sometimes you just need to look and say, what happened? What is, pause and say, okay, what are the true implications of this? Because everything feels like it has an implication.
Yeah.
Everything does. Most things don't. And then say, okay, are we having some of these problems because we're just not hiring good people? Which, yes, that's part of it.
Yes.
Or, hey, I have my paramedics, my EMTs who are bitter and wore out. Hey, maybe having them at the busiest station or having them on the busiest truck for 4 years, maybe mix up a little bit. They might be great at their job, and I know the experience is worth its weight in gold.
Yes.
But, maybe you should take your guys who are seasoned and say, hey, we're going to send you out to the slow station for the next while.
Mm-hmm.
Not because you're not doing a good job, but because we're giving you a... And I know it's not going to necessarily be received that way, but that's also because we never actually did that. We generally, when we take people off the truck, we say, hey, why don't you go take a vacation? it's not because, hey, I think you need I think you need to take a break for your mental health. No, it's because no, you're causing me issues. Get out of my face.
Yeah.
But doing the opposite of saying, hey, you're doing a great job. I can see you're getting a little tired. I can see you're getting a little frustrated. Let's take you off the really busy truck where you're take you from running 12 calls a day, 12 trips a day, 8 trips a day. Let's go let you have a few shifts where you run 4 or 3 and let you just emotionally, mentally recover. We'll bring you back, and like, but you don't have to just be at the busiest station all the time. In fact, that's not healthy.
No, it's not. And that's really good. Like you said, going from 8, 12 calls a day to running 4, that's a huge break. And I feel that in private EMS too, because there's days that we are on the road 12, sometimes 15 hours a day.
Yeah.
Like my last shift, we drove 400 miles, 2 trips. That's exhausting.
Yeah.
And then coming here or having a day off or going in the next day and running maybe 2 or 3, I'm like, I needed this.
Yes.
It's nice.
This was like I've had arguments. I've full blown arguments over this with my other boss of like how, like, hey, Sunday, every extent you possibly can, leave us alone. No trading. Don't try to schedule any extra like PR stuff that you can possibly help it. Leave us alone on Sundays.
Yeah,
and preferably Saturdays too. But okay, I'll give you Saturdays a little bit. Saturday afternoon, leave them alone. Sunday, and I get it. Like somebody's gonna say, "Oh, you only work every 3 days." Yeah, but when you're busy, and like guy I'm working with now, he started, and he's not run like a real busy, big township, borderline city department before. And he's like, the pace here is totally different than it is in the middle of the country. I'm like, yeah. So you might run only 5 calls here, but it's fast paced. You don't get a break. You don't get to catch your breath. You spend your first day off just exhausted.
Absolutely.
So that being able to say, hey, I know that the Sunday I work or Saturdays I work we're gonna do our stuff, do our chores and run calls, and that's it. We're not gonna be playing, dog and pony show games to impress people. And that goes such a long way.
It does. You need that mental and physical break. Because you get ran down running back to back to back to back calls. I feel it both places when we're busy. Like days like yesterday and today. It's been good.
Yeah.
We're not been overly busy and not extremely, I'm not gonna say the word. I won't do that to you.
Don't you dare.
But days like today are nice.
Yeah.
But then again, it can happen at any moment too.
Well, and this is the thing too. Like here, from my perspective, having been the only paramedic on this shift is exhausting because you always know no matter what call comes in, you are ultimately in charge. It's nice to finally have someone else.
Yeah,
and that is, even though I still have to be here responding to calls and whatnot. I'm practicing this also too elsewhere. Is like letting someone else write calls everyone is proving to take a huge load off because it's no longer
it's a weight off your shoulder.
I am still the senior guy. I am still, but that being said, I don't have to be responsible for every aspect of it.
Yeah.
At least I don't have to be directly responsible.
Right.
So there's a lot of things. I mean, we can keep on going. If we've gone,
we could. Well, hour and 10.
Hour and 13. Hour and 14 actually right now. No, we can keep on going, and this is where I want to start going though. Is like, what can we do besides just talk about? Because I don't mind complaining about it and throwing ourselves and
coming up with solutions or ideas to those problems. We need to start doing too.
Yes,
especially with the complacency. Don't be so complacent.
Yeah,
just okay. It's a simple call. They say it's this. Just do a full workup. Just give them what they need.
Yeah.
Hey, we did this, and this. Everything looks good on our end, but until they do this, and this, you don't know.
One thing I've never felt yet is I've never felt that twinge, and I'm not like huge on like wanting to do like refusals or
Yeah.
anything, but I don't feel this like, oh, what happens if like no, because I
A little cold.
I can tell. No, I don't feel this like twinge of like this like foreboding. Like, oh my god, what happened? No, because whenever we have to do like patient doesn't want to go to the hospital, okay, I'm gonna do everything in my power. I'm gonna try to convince them. I'm gonna
Yeah.
tell them, hey, this is my concern. Can you explain to me and can you understand? Do you understand what my concern is? We almost had this the other day, where it's like we didn't initially want to go to the hospital. We ultimately end up convincing her to. Very enjoying your bugs.
Yes.
Very wisely convincing her. But it's like you understand that we. It's not because I don't want to come here later. I mean, I don't. But
Yeah.
I don't want to come here and it be worse.
And that's what I tell a lot of
Yes.
people too. Let's go get you checked out.
Yeah.
If it's they find nothing, you'll be in and out a couple hours.
Yeah.
I'd rather not come back later, and you're in a cardiac arrest or you're having a big heart attack. Let's avoid that now. Let's take care of
Yes.
it now, right before it gets worse.
Yes. And if they still don't want to, then it's like, okay, I've done everything my
Yeah.
power. Do you understand this? It's not the signature that makes me feel
Yeah.
better about it. It is I have done as much as I possibly can. I have laid out for you what the risks are, what the benefits are, and that I
Yeah.
feel my concerns.
Sometimes I will say, I'm like, listen, if we come back, if this is what we see,
Yep.
there's a chance you can die after we leave.
Yeah.
And I don't want to come back here and have to call a funeral home.
Yeah.
Some people don't agree with saying stuff like that, but I'm going to be very real and upfront
Yeah.
with them. Sometimes people are like, oh, that's bullying. You're scaring them. So
No.
be it. I'd rather
Some-
do it now than come back and have to call a funeral home.
Well, sometimes, especially you get somebody who's short of breath or whatnot, it's like, no, I'm fine.
You're
Just-
not fine.
No, you can't.
Yeah.
You can't. This. I mean, this was a deciding factor the other day. It's just like you couldn't even stand up. You couldn't stand up.
Yeah.
So you're just gonna live. You're just gonna live sitting on your bed for the rest of your life. Nice,
I am not Kobe.
clearly. But I was like, no, it's like that's. But there, you also have to do everything. Some people just will, they just don't want to, and that's fine. You also have to respect that that's their decision of doing that.
Yeah.
But that has helped me immensely, is not feeling like this pinch of like, what if it happens? Like, no, do a refusal for the best of for best concerns for them.
Yeah.
Especially if you do refusal like framing as, and I shouldn't say just frame it because that makes it sound, make it sound like, but no, like if you do a refusal framed around the fact like, hey, I'm trying to make sure you get the best care, whether that's through me, whether that's through your doctor, whether that's through the hospital.
Yeah.
You will be so much further ahead than framing it as, this is BS. I just don't want to be here. You're wasting my time. That's what's gonna leave you with this. Oh man, maybe I misjudged the situation. Yeah, because you probably did. Honestly,
Absolutely.
if we're gonna be straight up honest, you probably did. So frame it as that, and you'll be so much further ahead.
Yeah.
And I mean, these things don't have to be major. As I said, they need major like overhauls, things you can personally do.
Yeah, and a lot of the times it starts with you.
Yes.
That's where it is. It starts with you. Sometimes it starts with the states,
Yeah.
laws, guidelines, protocols.
Mhm.
It starts with them too, but it's you, and you.
Well, here's one thing you gotta remember. We use this joke a lot. Every single policy has somebody's name on it.
Yes.
Every single, like, if you look at the fire code book, the thickest sections of those books, like your egress and entry
Mhm.
passageways, are the thickest because they have the most deaths attached to them. There's reasons why, and you look at most of the fire code stuff, and it's like, well, duh, you should keep, egress pathways open.
Yeah.
Duh, you shouldn't block the doorway. But somebody did.
Yes.
But some people did. And so, it's one of those things where it's, just remember that the reason why we have a lot of these protocols is because, not just because, oh, hey, we need to get some guidelines, but somebody somewhere along the line, there's protocols in our protocol that tell us how to do an assessment.
Yep.
Why? Because somebody somewhere along the line did not do an assessment properly or did half-assed it.
Yep, exactly.
So,
Like our backing policy.
just like our backing policy is there for a reason.
It's been there, but now it's being enforced.
Yes. Yes.
Yeah, you're 100% correct on that. Somebody did something, and now there's a rule.
Yep.
Written down.
And that rule is not fixing a problem. It's not fixing the personal accountability.
No, it's not.
So again, it goes back to, hey, you know what you should do.
You have to take accountability for yourself.
If you make a mistake, own up to that mistake, and then move forward from that mistake.
Yeah, you learn from your mistakes. Yeah. Take account for yourself.
Mm-hmm.
You screwed up. Hey, I screwed up. I know I should have done this, or I should have done that. Take accountability for it. It's okay. Like, okay, they recognize they screwed up. All right, from here on out, this is going to be what has to be done from here on out. Yeah. And like me, I've learned from my mistakes in life, and some people do, some people don't. But I'm not perfect. I've made mistakes.
No one is. But if we start teaching each other and help each other learn from mistakes rather than fearing those mistakes because there are blemishes.
Yeah, and that's why I try to teach new people how to do it the correct way.
Yes.
Don't get lazy. Don't get complacent.
Yes. Lazy and complacency. That's like where we're landing here. It's like that's like the sixth time that's been brought up.
Oh yeah.
So, oh boy. Well, as I said, we can go on about this in the nauseam, but no, I mean this is a good landing spot here. So I think we'll talk about next week what we're gonna do. But I mean, this is gonna become kind of a series of actually coming up with like solution ideas to not just. I don't want it to be like this one size fixes all thing. Yeah. Like one thing is like the silver bullet because there is no silver bullet.
No.
But we need to start thinking about these things and thinking about them in a way that it's not my responsibility to fix you, not your responsibility to fix me or anyone else. We can help each other. That's not what I'm saying. But we need to start giving people resources and stuff, and instead of saying, "Hey, I'll do it for you. Now you pick up what I did for you."
Yeah. I mean, agreed. You hit it pretty big. You can, like you said earlier, call in the hospital to bounce ideas off. You can bounce ideas off me and vice versa. Yeah. And I do that. I do it with my partner at work all the time. Like, hey, what about this, and this? And she's like, oh yeah, okay, but what about this? And like, hey, that's not a bad idea. Let's try this. Yeah. Kind of like middle ground area. Take accountability for yourself, and you'll do good.
I promise you, we don't all know everything, although we think we do. I think I do. That's why we're doing this podcast. We think we know everything. All right. Well, on that what's a mutual admiration society. I've been Tim.
Jeremiah.
And this has been Conflict and Leadership Coffee Table Edition. We will be next week, and we actually sound good now. So, hey, there's perks all the way around.
14th.
The 14th. Oh, you got it written down.
Yep.
I think we're. Are we behind today?
Oh.
No. We'll be back on next time. So, for those of you who are armed service members, enjoy your holiday. I think it's on Monday.
Yes, it is.
It is on Monday. Enjoy your Veterans Day. Go out. If you know somebody who's a veteran or who served, go thank them, and actually thank them for what we're able.
Thank you for your service, Timothy.
Now, I will I will end you. So, but no, just remember that it's those people who are the reason why we can in this country. So, till next time.